Awesome. Well, here we are. Um, to start off with, uh, my name is Daniel McCormick. Here having a discussion with Jason McCormick, my father. Um, and we'd like to talk to you all today about healthcare. For the past 23 going on 24, I believe, years, Jason, you've been working in the healthcare industry, is that correct?
Yes.
And during that time, in the past 23 years, we've seen a tremendous change in the healthcare industry. From the time that you first started until now, um, the public perception of it now is that healthcare is too expensive. And we've been working in the industry. I've only been working in it for about 2 years now. He's been working in it for about 23 years. And we realized that a lot of the public doesn't necessarily understand why it's so expensive. And so we wanted to have a discussion, have a conversation about the backside of what's going on in healthcare. And by backside, I mean the financial side of it, the side that people don't really talk about, in hospital administration, and how, the finances go, the accountant's perspective of this whole industry. So wanted to bring Jason in. He's been working, like I said, for the past 23 years on all of this, and it's been a subject of big discussion recently, especially with the whole COVID thing. So first off, how you doing, Jason?
Doing very well. Thank you for the opportunity to sit down and share some experiences and some insights about a very important topic.
Awesome. How's COVID treating you?
It's going much better this last few months. So we're seeing a decline in many different communities with regards to tests and people being admitted. And certainly glad to see that the masks mandates are being lifted in certain states, and we're able to get out and do a little more. Certainly the nicer weather helps as well.
Awesome. So to start off, costs. In the short of it, we'll give the short answer up front, and then we'll go into the long answer. Why is healthcare so expensive?
Why is healthcare so expensive? Well, it's a very large, very complicated industry. Um, I think the short answer is being that it's such a large industry and it's involved with a lot of technology, a lot of professional issues. There certainly are. The government pays for a very large portion of the costs. There is I think the short answer is a dysfunctional system, a very
Mm.
dysfunctional system that isn't well thought out. It's not addressed in a manner that's designed to be efficient, I believe. I think it's quite convoluted.
Okay, so a long, not thought out system. What do you mean by that? So you're saying that the problems are systemic. What would be the first problem, in your opinion, of why that is?
Well, just backing up and just giving a brief background with regards to what is healthcare. The basics of it is a person is sick, they have a condition, they need to go to see, in our country, a physician, a provider of some nature. That could be a nurse practitioner, a PA, or other healthcare provider. Maybe it's a dentist, maybe it's a mental health care counselor, something of that nature. And they uh, diagnose the situation, and then they order various tests, things of that nature, and then they order treatments. And so everything is controlled by a third party. Uh, and for a large, extent, that's because these people have advanced training, and we believe that is needed in order to deal with the complexity of healthcare. There's very little, really very little, that individuals, non-healthcare individuals, can do for themselves. Go to the grocery store, for example, and look at the medications aisle. You'll see some different pain relievers. You'll see some cold medications, sunburn treatments, maybe something to deal with an upset stomach or something of that nature. But there's really very little that's available to us to do on our own. Recently, there has been an advent of essential oils, and there was a lot of individuals getting behind that movement and seeing a lot of impact because of that.
Mhm.
where they are empowered because it's seen as an alternative medicine to be able to do some things. And that points to the fact that there are people interested in taking a greater control of their healthcare. But in the core of our system in the United States is somebody else controls our healthcare, and that would be a healthcare provider. And it puts them in the center of the system. And the challenge that we have is that the number of providers that are available in the industry is insufficient to meet the demand. We look back, healthcare is really about populations. And as we look back in the past, the World War II generation came home, and we had the explosion of the baby boomers. When they got to be college age, a lot of professional organizations put mechanisms in place to prevent that overwhelming number of people from coming into their profession and decreasing compensation to that profession. And that's very true of the healthcare industry, of the medical professions. Well, here we are on the backside. Baby boomers are retiring in droves and seeking more care. So demand for healthcare is up, but the availability of physicians is way down. And it's no matter what the government does, it can't get around the fact that there is supply and demand pressures in the market. And so if there aren't enough physicians, then a few things happen. We get a decrease in the quality of healthcare because we're employing everybody who possibly can have a license, even though maybe some of them shouldn't be practicing. Um, we're stretching them beyond their means because they're burnt out, they're overused, there's not enough availability. People aren't able to get in quick enough to get health care. But most importantly, as we're talking about in this country, the costs of care go up tremendously because there's just not enough. And so they can ask for more money. And it just drives up the cost when we don't have enough physicians. Maybe it's mid-level providers like nurse practitioners, PAs, maybe it's nurses and other techs. Healthcare is made up of 70% of the costs of healthcare are directly related to people because it's a service industry. And so if costs are going up, most likely it's because of a supply and demand issue. There's not enough people to do the care that's needed. And it's only obvious that with the retirement of the baby boomers, the demand for healthcare is up while the supply of workers is down. And that is causing a significant shift. And the way that we're attempting to resolve that isn't a real solution. In 2010 is when the first wave of baby boomers were officially able to retire. Certainly, there are probably people who retired a little earlier than that, but that's when it officially begins. And so here we are, 2021. We're 10 years into that generation who have retired. A lot of people have left the industry. We've also had an increase in just the utilization. They're on Medicare, and they're taking advantage of those benefits. So what's driving the cost there, or what is the government and what are other organizations trying to do about that? Certainly, we saw in 2010 the Obama administration implemented what we know as Obamacare, and that was a significant um, healthcare reform bill to try and address the fact that when the government looked into the future and perceived how much the cost of care would be, versus the available resource of funds for the Medicare program, other governmental programs, would they have sufficient resources? And it was very clear that they would not. And so they began implementing a variety of changes. Most of those are designed to otherwise just simply impose a, a limit on how much providers are paid. So there were programs that came out saying, here's what we're going to do to reduce compensation for professional services, and here's what we're going to do to reduce compensation for um, hospitals and things of that nature. And so they're addressing the symptom being that due to a lack of supply of professionals, costs are going up. That's the symptom. The cost is going up. And so they're addressing the symptom by saying, well, we're just going to mandate that those costs not go up because this is what we're going to pay. But those providers switch over instead of being paid directly by Medicare. Medicaid, other programs, they go to work for hospitals, large practices, and their costs go up, and that cost gets shifted to other areas, other ways of being paid for. Some organizations are struggling financially, and maybe they're passing taxes to their local community so that they can make up for that difference. But you just can't get around the fact that those providers are very powerful and they can demand a higher wage because they're in short supply, and there's no alternative, or very limited alternatives. There are a couple of alternatives that have happened over the years. Certainly, shortages of professionals have been going on for a long time. Um, we have been importing physicians from other countries for many years. 1 in 3 physicians that practice in the United States is most likely foreign trained, foreign born, foreign trained, and they come into the United States and they work under some form of a visa, and after a period of time they get a citizenship, and then they can go practice anywhere they want. But it's very common to work with a foreign trained medical professional. Great people. I love them. They're excellent. I don't have any question with regards to the quality of care. It's just disappointing that we can't ourselves. We can't give those excellent jobs. We can't take advantage of the intelligence and the high achievement of our own citizens because of this issue. That's a side impact, but I just wanted to point out that that's one substitute that has come about as we've had a shortage. We have taken physicians from other communities, and the downside of that is those communities, those countries don't have as many physicians as they need. We've also have sought resources from what we call mid-level providers, nurse practitioners, PAs. There's a greater role of the nurse and other technicians working under protocols, but it's still, with all of that, it's still extremely insufficient to be able to meet the demand. And we're only halfway through this retirement process, and we're not even into the worst stages of this expense. When you see the baby boomers, the bulk of them reach their 70s and 80s, upwards of 80s, when they're really consuming a lot of healthcare. There will be insufficient resources. Plus, the millennials will be seeking care at that time, another large group of people. So.
Yeah, so we're seeing this increased amount of healthcare, and you said that Obamacare seemed to address a symptom. Was there anything that good that came out of Obamacare in your view of things?
Well, there were certainly several things that were positive about Obamacare. It was a very large, sweeping program, many different aspects. It appeared to me, having read that bill when it came out and being involved in the industry and its subsequent implementation, that it did fill a lot of holes in some very detailed, intricate aspects of healthcare. It did put a reliance upon the importance of preventative healthcare, that we do need to, when we look at the factors of the cost of healthcare, prevalence of illness is very important. And so whatever we can do as a country to decrease how much we access care, that makes a big impact, truly does. And if we can identify illnesses on an early stages of care and get that addressed, then we reduce the cost of healthcare. It's great logic, but I come back to the prior issue, which is there's not enough physicians. So, we need more people to get in and see their doctor, and so that they can get these preventative testing done and they can get treatment for conditions at early stages. Yet there's not enough providers available in different parts of our communities, metropolitan or rural or other areas. It does show tremendous cost savings when we can do that. Whenever we can change, when we look at the cost of healthcare, we find that about not more than 10% of the cost is really due to genetic issues. Usually 90 to 95% of the cost of care has to deal with lifestyles and how we care for ourselves. So diet, exercise, safety practices, things of that nature have a big impact. And so that is something we can do ourselves, and that was a positive aspect that came out of the Obamacare program. Yet, when I come back to it, supply and demand, you can't get around it. None of the programs, I've not seen a single program over the last 2 decades, 2.5 decades I've been in the industry, where the government has intentionally helped create more medical programs in the United States,
Hmm.
and on a material basis, and really put forth more providers.
Yeah.
There's not enough. Most recently, under Biden, there was, I think, an executive order saying, well, we need to look at physician burnout, what's happening there, and we need to come up with solutions for it. But still, it doesn't get at the fact that we have an increasing demand for healthcare services, and we have a decreasing per capita supply of providers and other technical aspects. And I just don't see it. I don't see the federal government stepping up to the plate and figuring out how. And I often hear the excuse, well, you know, funding a medical school is extremely expensive. Well, yeah, that's a defeat. The fewer and fewer physicians there are,
Hmm.
it's physicians who teach physicians. So the fewer physicians you have, the more costly it's going to be to employ physicians to teach physicians. So if you want to fix that problem and you want to fix the overall healthcare problems, you got to invest in it. You got to get more organizations out there training physicians. I mean, we've got medical schools in the Caribbean. There are countries who have created whole industries to train physicians just outside of our borders so that those people can get trained and then come back inside the United States. Why can't we do that? Why can't we open up the number of slots that there are for medical professionals? I'm told that, for every 3 applications that there are to get into medical school, 1 is accepted, but all 3 are qualified.
Yeah.
So we turn away 2/3 of the people that could otherwise go through medical school, be successful, and enter the industry, and be a productive resource in our country.
Yeah. Yeah. One of the things that we get to see from our side of this whole process is the fact that we're looking at the financials of a hospital. We're looking at the administration. We're seeing that there aren't enough doctors, and these doctors are able to charge exorbitant amounts for their wages. Um, and one of the interesting things that I've seen in my past 2 years of looking at this industry is just how much of a hospital's costs are um, go to those physicians, go to those healthcare professionals and those providers. How does this affect hospitals in a broader sense? Because I think that's something that we don't necessarily think about. We are seeing these extremely high costs when we go to the hospital, right? If ambulance, emergency room, if you know, heaven forbid, you have to use those services, that should be the last thing. It should be preventative care. I think that you mentioned that should be our first step toward healthcare. But when we do have to use those things, and even when we use the preventative stuff, there just aren't enough doctors, and so we're seeing these high rates, these high costs. But you mentioned in there that also that they're going and joining these other organizations, these healthcare providers, because being a private practice isn't giving them the money that they want, or that they feel that they are worth in today's economy, being what supply and demand it is. What is this doing to hospitals? Because you and I have worked with a lot of hospitals, so just talk about that for a little bit. What is happening to our rural access hospitals or even our inner city hospitals as we're seeing this supply and demand change?
Yeah, this phenomena is common, regardless of rural or urban. As I spoke about at the beginning of our conversation, the core of our healthcare industry is based on this one fact. It's based on the fact that people can't care for themselves. They're not smart enough to care for themselves, and they have to seek direction, care management from a professional, being a provider, a doctor, a nurse practitioner, something of that nature.
And
They're the
that's
only
not
ones
to
who
say that
have the
people
skill.
aren't capable. It's that that healthcare is extremely complicated, right?
Is complicated, and I'm saying that we should give people reign to do everything, but we could give them more, and that would be part of a solution. So that
Mm-hmm.
not every cold or simple infection has to go to a doctor to get a script for. There. I think we can move that bar up because our education, our level of intelligence as a community has grown. But I wanted to point out that That puts physicians very much in the middle of the healthcare system. Everything is dependent upon, they decide what gets done.
Mm-hmm.
Okay. So when you go into a healthcare system, um, in order to get orders for labs, for x-rays, for prescriptions, for surgeries, things of that nature, a doctor has to order it or a doctor has to perform that service. So if you want to have a hospital, you have to hire doctors. So there has been a long-standing tradition of cost shifting. And so we said, well, it's okay to lose a little bit of money in hiring the doctor because we can make up for it on the downstream pieces of this transaction. We can make up for it on the labs and the x-rays and on the surgeries and things of that nature. Well,
Mm-hmm.
you know, that started off okay back in the 90s or the early 2000s. You know, maybe you were losing a little bit of money on your physicians. Maybe you had a $2-3 million practice and you were losing $100,000. Not that big of a deal to make up for that. But here we are in 2021, reimbursements have been reduced and inflation has pushed up the costs of running a medical practice. And you're no longer losing 100,000, you're losing $1 million. So how do you make up for that in a hospital? There's a concept that I refer to as reverse leverage, where let's say, you know, hypothetically that if a hospital had a 10% operating margin, which it does not, um, it would take to overcome a $100,000 loss, it would have to have $1 million of downstream revenue to make up for that. Okay. But if you're losing $1 million on a clinic, you need $10 million of additional revenue to make up for that just to get to break even. Okay. In reality, the national average for a rural hospital or most hospitals is a 5% operating margin. So you need twice that. If you're losing $1 million on a physician practice, you need $20 million to overcome that in additional revenue downstream. And it's becoming harder and harder because, as I pointed out, the biggest impact here is we got this retirement of the baby boomers. The industry was healthy prior to 2010 when those baby boomers had great insurance. They're getting a lot of orthopedic and other kinds of cardiovascular, other kinds of care. And they were on commercial insurance and it was paying well. There weren't a lot of people who were on Medicare. And so hospitals were making a lot of money. They weren't losing much on Medicare and Medicaid because there weren't a lot of people getting care through those programs. Well, we're the opposite now. There's a lot of people getting care from Medicare and Medicaid, very few people getting care from commercial, and the losses are much more significant. And we're just not able to make up for that. And you know, I work with a lot of hospital administrators who continue to have that 1990s or 2000s mentality. It's okay to lose money on physicians because you make up for it in the hospital. And you know, I go in and those hospitals are losing millions of dollars. And there's, you know, what is needed to fix that is quite substantial. It quite impactful to any community. You have to decrease the number of physicians, you have to restructure, you have to impact a lot of different things, and it's not pretty, it's not beneficial. We need to get to the point where we discontinue. You know, this probably you said it correctly at the beginning of the conversation. The issue is systemic, and the systemic issue is it's I would describe it as cost shifting. We're always trying to get somebody else to pay the bill. And that's been going on in healthcare for many, many years. I mean, you go back to Greece and, you know, Plato and, you know, those Hippocrates, those kinds of times. And, you know, it was always seen that, well, you know, we'll charge the rich people a little bit more and that'll make up for the fact that poor people can't pay enough. And between it, you know, as a physician, I make enough. That's, you know, it's prevalent in the industry now, but nobody wants to do that anymore. I mean, Medicare, they're the king, right? They belong to the federal government. They have all of the data. They get information on what it costs to run healthcare, and they set it at cost. And then they determine, well, we also have the Medicaid program. We're gonna reimburse for Medicaid program 20% less than we reimburse for Medicare, and we're just going to make those providers make up for it on commercial insurance. Well, that's very much on the decline. There's not a lot of commercial insurance out there compared to what there was 10 years ago. So that kind of cost shifting isn't working anymore. And those commercial insurance companies have gotten wiser, and they've come out and said, we don't want to pay. It's not our job as a private industry to pay for the Medicaid program in your community because you don't want to increase taxes. And so they have gotten out of a lot of those kinds of programs. They've taken jobs overseas, they've outsourced things, they've decreased benefits, some of them given up on providing benefits altogether. But so cost shifting is the biggest impact. As you would ask, what is it that's impacting rural healthcare and all healthcare? As these losses continue to grow because we reduce the reimbursement, but our inflation is still a very real issue. Those losses have gone from $100,000 to $1 million over the course of the last decade, and that reverse leverage, those hospitals just can't make up for it. They can't pull it out of a bottom line. They can't shift it over to a commercial insurance. They can't shift it to somewhere else. And it's going to come down to a couple of things. It's going to come down to how can we get more providers out there so that we have truly enough people to care for the number of people who need to receive care, and they can get seen by a doctor within a reasonable amount of time, 2 or 3 days, 2 or 3 weeks, not months and months of waiting to get in to be seen. And number two, everybody has to pay their fair share. Medicaid has to pay more, Medicare has to pay more. And if they have to raise taxes to do that, then that needs to be considered. Commercial insurances, everybody has to pay. They can't expect to get free healthcare and allow somebody else to pay for it. Everybody wants to avoid, how do I pay for my healthcare?
Yeah. So you're saying that these costs are going to have to go up. That's something that's been interesting to me. Is that it's something that I didn't necessarily understand about the private insurance community or private insurance industry, is that they set how much they're going to reimburse based off of Medicare. And something that you and I have talked about is the fact that Medicare is not increasing how much they're reimbursing, even though costs continue to go up for Medicare.
Yeah, a very good topic for us to discuss. So, as I indicated, under the Obama administration, we passed Obamacare. One of the provisions of that was to decrease or do away with what was called the Doc Fix. There was supposed to be a program in place going back, even before 2010, where the increase in compensation to physicians under the Medicare physician fee schedule was limited, so that it created a sustainable growth so that the Medicare trust fund could remain viable. Well, every year there would be lobbyists and Congress would override that, and they would give not quite a true increase that was equivalent to inflation, but a little bit more. Well, under Obamacare in 2015, they passed a program called MACRA, and it goes hand in hand with a subsequent program called MIPS. That basically is a program where they said, okay, we're going to decrease the Medicare physician's fee schedule. We're going to withhold money. And then if doctors meet certain reporting requirements, certain expectations for how they run their practice, we'll give them that money back. In fact, if for those practices that do really well, we'll give them more, and that'll be paid for by those practices who don't. So they tax the system to pay for this system. So that went into effect in 2015. So starting in 2016, the Medicare physician fee schedule declines all the way through 2021. Now they move a few codes around. They'll pay this code a little higher this year, but they took it away from other codes. So it looks like some people got a raise, but in reality, the total funds going into the whole process is down. So that's what Medicare has done to try and deal with this inflation. And they just said, okay, we're not going to put more physicians out there. We're just going to say how much we're willing to pay. Mm-hmm. And somebody else is going to have to deal with that. So the commercial insurance companies ride on the coattails of Medicare. So they set up contracts with all the providers, and they say, well, we're going to pay 110% or 150, 180% of Medicare. So if the Medicare fee schedule goes down, reimbursements from commercials also go down. And that's very much what the commercial insurance companies have been doing for the last decade. They're not calling anybody up and saying, hey, well, I realized the Medicare physician fee schedule went down, so we're going to give you twice the increase this year to make up for it. No, they're excited about it.
Yeah,
It's working
they don't
well
have
to
to
their
pay as
benefit.
much.
Yeah. But in the meantime, physicians, if you look at a kind of a diagram that showed here's how much inflation is, and here's how much doctors are being reimbursed, there's a 30% gap since 2015. Rates on a real basis are 30% lower than what they would have been had they stayed under the same process. So, basically professional services have declined by 30%. And it would appear to me, when this happened, in 2010, Obamacare was passed, there must have been a national convention. I'm just saying that tongue in cheek, but it was very clear to the providers that the future of healthcare reimbursement to private practices was going to be dismal. And so all the physicians began courting large practices or physician groups or healthcare systems to become employed so that they could otherwise negotiate with those organizations based on a different process and let those organizations deal with the fact that reimbursements were declining.
Yeah.
And they've done that. There are very few independent practitioners out in the industry at this point as compared to what there were 20 years ago.
Yeah. So they're all joining these large organizations, as you've said, um, continuing to get paid more and more as everyone wants a raise. They're joining these organizations, and then from what we've seen, a lot of these organizations are actually suffering from that, right? And so we have whole hospitals that are either selling or going out. Is going out of business? Is that what you've seen?
Yeah, a variety of things. They could be cutting services, it could be cutting compensation to other groups in the healthcare industry that don't have as much power and cloud, a variety of things, taking over different services, trying to come up with a way to, as I described before, cost shift. We're not getting enough here, so we're going to shift it over there. But the whole intent, I mean, the strategy is that, well, we'll all work for the same organization, and because that organization is larger, you'll have more clout to go back and negotiate better compensation with the payers. Um, so here we are. We all studied back. I don't know what it was, middle school when we studied history and we learned about antitrust and how at a certain time in the U.S. history there were these great big organizations, great big companies, and they controlled everything.
Mm-hmm.
And we put a lot of laws into place in the 1930s to diminish that. Well, that's the direction that we're headed. Several very large healthcare systems. There's already only a few large healthcare insurance companies. There's probably 5 of them out there, and so we just have this proliferation. There's really no small providers. The United States talks about saying that the perfect economy is to have lots of providers and lots of consumers, and we let the market adjust, and everybody has equal access to information. Well, we don't have that. That's not how healthcare exists. We're going in the direction of having very few providers, very few insurers, payers, and it's quite dangerous, I think.
Yeah, yeah. So we're getting closer and closer to that kind of like that trust where you have a whole bunch of providers all grouping together, you have a whole bunch of payers all grouping together, less and less in the market compared to the amount of service that we need.
Yeah, but I would, along that line, I would say that still the favor is put upon those organizations that have an ability to reduce rates to providers. There's very seldom does the FTC say anything to large insurers who are otherwise just forcing down reimbursements to physicians. And they say, well, it benefits consumers. It benefits the patient in the end. Well, the real real people involved in this transaction is the provider and the insurance company. The provider's doing something and needs compensation, but they say, well, we don't really care about that. We care about what people pay in insurance premiums. So they'll protect the insurance companies, But they do not. I see a lot of intervention whenever physicians try to get involved and try to combine together to come up with some kind of a way to negotiate with such large organizations. I mean, imagine, if you will, two or three physicians, one physician in a private practice trying to ask for better rates from Blue Cross Blue Shield. I mean, you're lucky to get Blue Cross Blue Shield to give you a copy of their, their compensation schedule, let alone have a conversation about increasing your rates. I mean, they're
Yeah.
pretty notorious for just simply saying, no, this is what we pay. And if you don't like it, maybe get into a different industry. This is it. This is what we pay.
Yeah.
There's no negotiation.
Yeah, you and I have looked into the insurance compensation side of things, and that is definitely not a fun thing to do. Is go to a large organization on behalf of a small practice and say, hey, we need to be paid more, and it's just not happening.
I take, for example, the state of Wyoming. Blue Cross Blue Shield in the state of Wyoming it pays everybody the same amount. That, well, you would say, well, that's fair. And I would agree that that's fair, but there's simply no negotiation. One payer has exclusive rights to be able to determine what is paid. It receives no input, no appeals process, no request justification, no quantitative information from the provider saying this is what would be fair and reasonable compensation for the services. They just decide what it is and when it will be changed. And the only advancements, the only success that the group of providers in Wyoming have had in the most recent couple of years is they finally got them to disclose what the fee schedule was, and that took a lot of pressure and finagling to do. But there's very little impact on leverage. There's very little influence that physicians can have, and so I don't blame them for saying, you know what, there's nothing I can do, so I'm going to go to work for a large healthcare system or a large practice, and I'm just going to, negotiate with that organization based upon some kind of a national compensation database, like MGMA has one, and to where physicians get in and self-report what their incomes are, and then physicians then use that to be able to say, well, this is what I feel I need to be paid because this is, across the industry, this is what other physicians are being paid. So data is a little suspect, but I just wanted to point out the fact that they've changed the conversation in terms of what hits their bank account by going to a healthcare system or a large practice and saying, pay me based on MGMA, then you go deal with the insurance companies. Still, those hospitals aren't able to do anything different with those payers. I don't see significantly improved. Every once in a while, maybe there's some really old contracts, but very seldom even the large practice is able to do much. We're really getting down to the point. I foresee situations here in the near future in which providers begin saying, we've had enough. I'm not going to participate with this insurance company. It's very hard to say that. Nobody, people in healthcare want to care for people. They don't want to turn any group away. But it is down to the point where the only mechanism that physicians have, organizations who employ those physicians, is simply to say, we cannot do business with organizations that don't cover the cost of healthcare. We're not going to do business with you, and get out of working with insurance companies. Being an insurance company, that's a falsehood anymore. Just wanted to point that out. 10, 20 years ago, a company would go to an insurance company and say, well, sell me a policy, insure my employees. And they would say, okay, here's the premium. And the insurance company would truly underwrite. They would cover the costs of that practice. Mm-hmm. And so if they were, you estimated the total premiums were $1 million and the actual cost of healthcare came in at $1.1 million or $1.2 million, the insurance company lost money, but they paid for that. Or if it come in at say $800,000-$900,000, then they made a little bit of money. They generally made money, but they insured it. They actually covered that risk. Okay. Under Obamacare, there were a lot of changes, and one of them was taxing insurance companies and limiting the amount of profits that they can incur. A good thing. I'm not complaining about that. That led a lot of insurance companies to say, okay, we're no longer going to insure people. We don't want to be in the insurance industry. we're going to help large employers and even medium-sized employers set up partially self-funded insurance plans. We're just going to process the claims. We've got a set of contracts with the providers, and we've got software to be able to process claims. We've got some offices to be able to manage care, ask for pre-authorization. So we're going to provide those services, but we're not really going to insure anything. The risk is either going to be on the provider, or the risk is going to be on the company, the employer. And so they've gotten out of the industry. You ask a representative for any large insurance company these days, Blue Cross Blue Shield, United Healthcare, and they'll say somewhere between 80 to 90% of the claims that they process are for large employers that are partially or fully self-funded. Only less than 10% of the claims that they process are actually an insured product of any nature. Insured products are usually taken care of by the federal government in the form of exchange plans, things like that, where they subsidize a private company to provide healthcare insurance to individuals who buy insurance on the claim. That's a separate subject, but I just wanted to point out that we use the word insurance, but that form and function is dying. It is going to be dead in the next 5 years. Either the employer has a large group funded plan and they're dealing with the risk, they're the one insuring the patient, or a reinsurance company is, but the insurance company doesn't. They just process the claim. They're a third party administrator.
Yeah. 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 Which would be a reason why we're not seeing businesses provide those insurance packages anymore. I mean, I've looked around to different jobs in my area. Very little provide healthcare benefits, and then the ones that do, it's a $5,000, $10,000 deductible, and you have to reach certain things, and it's a healthcare plan that's not comparable to the industry standard even 10 years ago.
Yeah. I had a similar, I'm a small business owner providing insurance for myself and my employees. And so early on, I looked at that, and $2,500 a month to buy an insurance for just one family. And that's with between a $5,000 to $10,000 deductible. So I was upwards of $30,000 to $50,000 out of pocket before the insurance company actually paid for anything. And it got to the point where it's like, why give that money to the insurance company? I need it to pay my claims because I'm the one paying the first dollar. I'm the one paying the deductible. So I switched over to an alternative form of insurance. It's an organization that pools people based on a religious or other belief, and they share the costs of healthcare. And I found that alternative form of insurance. It's not an Obamacare plan, much more cost effective, and work with me in different ways. And so I just wanted to point out that as Americans, we are intelligent. We do find solutions, and when we're pressed with a challenge and an obstacle, and we're given the freedom to do so, we come up with ways to solve things. And there are some solutions that are out there. I wouldn't say it's all doom and gloom, but I would say that the preponderance of the industry is still headed down a road that is detrimental to us as a whole country, as a community, and especially for our businesses and our families. People can't come up with a $5,000 deductible. I see it all the time. They elect for these plans because they save $50, $100 a month on their premium through their employer, but then they actually have a healthcare expense and they have to pay for that deductible. It all goes to bad debt. It doesn't get paid. Their people's credit is ruined. The hospital doesn't have the money. There goes cost shifting once again, where the hospital has to shift costs that didn't get paid by this patient to another patient, and nobody's paying enough to cover the cost of healthcare. So it's a self-defeating and self-perpetuating problem.
Yeah, and large portion of this, as you've said, is because supply is simply just not high enough. We do not have enough providers of this healthcare industry. we're at 45 minutes now. Is there anything that you wanted to touch on before we wrap things up?
Well, I'd just like to talk about some solutions. You heard me indicate a few of them over the course of our conversation. These conversations are meant to help business owners, government leaders, individuals find solutions. We want to talk about what's the issue. Healthcare costs are increasing, and they have, despite all kinds of government interventions over the last 3 decades, they continue to increase. And that even now, what is being done is insufficient. It's not addressing the real issue. Yet people still need health care. And so, what are some of those solutions? Speaking to business owners, I would encourage business owners to work with brokers, work with consultants such as myself to be able to identify how can I set up a partially self-funded healthcare plan. Those are important, and to structure their healthcare plan in the right way. I'm not a believer in high deductibles because they discourage people from getting care early in a disease condition, and that's the wrong thing to do. We need to get people in to be seen by providers as soon as they begin to experience a condition so that they can get it treated in an outpatient setting before they get to the emergency department or the inpatient area. So partially self-funded or fully self-funded plans for medium to large employers are very important, and structuring their benefits is important. I think, speaking of the individual, as I indicated, 95% of our costs of healthcare deal with our lifestyle. I'm the first to blame. I'm a 51-year-old person, and I need to lose a little weight. I need to exercise a little more. I need to eat less sugar. I need to avoid things. And so it's important for each of us to understand our genetic history and to make those changes that will make it so that we're around for the future, that we're there for the wedding of our children, or the birth of our grandchildren. We got to find those real reasons to change our life. It can be hard, but if we find real reasons why, we can come up with the energy and the motivation to change, and that has big impacts on ourselves financially, as well as our companies and our communities that are struggling with those issues. Would encourage you to look at alternative forms of healthcare and healthcare insurance. There are different ways to come up with paying. You can go and contract directly with your local practices, and they'll cover your care for you instead of buying it from an insurance company. If you can't afford Obamacare, $3,500 for a family, at least go to a local provider and say, hey, I can pay $70 per person in my family, and you can cover me with primary care. There's other programs coming out like that. But I do think that as governments, we need to put aside the politics, put aside the self-interest of lobbyists. We need to really look at what is changing, what is causing the increased costs. And as hard as it may be, we have to address those issues. We cannot get around supply and demand. The federal and state governments have to come up with ways of putting more providers out there in our communities, more nurses, more lab techs, respiratory therapy techs, all of those folks, nurses' aides to work in our elder care, all of those things. We need to get more people working in these industries by having the right training and investing in those training programs and keep those jobs local. That's important. But healthcare insurance also needs to be reformed more. There's more that needs to be done. Anxious to have conversations with more business consultants such as myself, with business leaders, with government leaders, to come up with real solutions that are going to help. I'm concerned because I've seen it go on for so many years. We haven't turned the ship. We're not headed to a safe port. We're headed out into stormy waters as the baby boomers continue to age, and the only solution we really have is to force down compensation to providers. We're just going to end up with not having enough. People are going to be going across the border getting care from other countries in order to get care they need because they can't get it from the United States. Is that ridiculous? The United States can't provide health care to its own people? I think it's ridiculous.
Yeah, definitely. And I think it's definitely a problem that we're going to start to see more and more of. I definitely agree with you.
What do you think? As a young 26-year-old professional, what are your concerns about healthcare in the future?
Um, I don't think it's going to be around for me. I don't think that. Well, one, I don't hardly ever go to the doctor anyway. I'm young. I try and stay fit, and haven't had a need. Even with the whole COVID thing going around, I haven't had a need to go to a doctor. When I have had a need within the past 2 years, I've done telemedicine, which has been um, much cheaper and convenient option. Just call up a doctor, tell them your symptoms. Maybe you hop on a video chat, and they tell you what's up. Prescribe drugs for you. I did that. They sent it to a pharmacy near me, and went and picked up the drugs and felt better 2 3 days later. Now that doesn't always work. That works for a little bit, like you got a flu or something. You're young. You don't have other comorbidities, but like when you're hitting 60s, 70s, even 50s, and you've got other comorbidities where diabetes starts to show up, depending on your lifestyle, or you have pneumonia on top of being a smoker your whole life, then things start to shape up. And as more and more people my age are doing all these different things, I don't think that we're gonna have a a healthcare plan. I don't think Social Security is going to be around. I don't think Medicare is going to be around unless it's um, unless Biden or Bernie have their way and we go to a Medicare for all system. But I don't think that's going to be good healthcare anyway, because a large portion of the problem that we have with healthcare right now is that it's being controlled by the government. I'm not sure if the American Medical Association is part of this problem, or if they're part of the government, but the government isn't stepping in and saying anything, and they're reducing costs and they're reducing how much these healthcare industries are being compensated, all while costs of care go up, innovation in care goes up. All this stuff goes. It's just going up and up, and the government isn't paying more money, and so we're just eating away at the fund that of Social Security, of the tax-based revenue that we already have. Baby boomers are going to eat through that in no time flat. So I don't think, for my generation, for the millennials, I don't think it's going to be around. I think that Social Security is going to be cut at the very least. I don't think that's going to be around. I don't think that healthcare is going to be around. And if it is, I don't think it's going to be very good, because we're not addressing these fundamental problems like you're saying. We're not addressing the fundamental economic problem of, if costs are too high, look at the supply and demand chain, and you'll often find a solution there. Why are the cars that we have now are better quality and cheaper than they would have been 20 years ago for the same amount of features that you get on them? It's because you've increased the supply, and you've been able to meet those economic changes, right? And so we have better things for less, and we're seeing better care. We're discovering, we came out with a vaccine for COVID in less than a year. But the medical professionals who are assigned to be doing that aren't seeing the same sort of compensation, or they are seeing increased compensation in some, if they join these big communities, and then they drain those communities dry, because we're just not seeing a fundamental increase in costs. And the more and more demand that is put on these people, the more money they ask for, and our demand for services is just so high. I have a very pessimistic view for my generation.
Yeah. Let me bring that home for you. We just went through 100-year event, this pandemic due to the coronavirus. And this is boil it down to this one simple statement. We shut down our economy. We shut down our country And that cost us over $9 trillion. Why'd we do that? We did that because our healthcare system did not have the capacity to care for the expected number of people who needed the care. All of this cost savings by reducing the number, the compensation and not having enough physicians, and we've done that. We've stepped over dollars to pick up dimes. It cost us over $9 trillion. Many people's lives were displaced, jobs were lost, industries shut down because we did not have the capacity to deal with a fundamental government obligation, which is to provide for the health and security of its citizens. And they didn't do it. The only thing that they could come up with was shut the country down until we can come up with a solution, and then put a financial burden on people such as yourself, the next generation, for many years to come. And what I'm advocating out there is we have to start doing the opposite. We have to put enough providers out there in our communities that we don't shut down our country because we don't have the capacity to care for our country. That's what I'm saying.